Hello. So Dr. Sanjay is there? Sanjay Kumar? Sanjay, somebody has to come from API group, some senior person. Is there anybody from API, senior people from API? Anand,
जी जी गुड इवनिंग सर
good evening. Is there anybody from CSI group?
नो
Sorry,
सर नो सर
none.
नन नन सर
अच्छा, चलो ठीक है, we'll start then.
ठीक ठीक ओके सर
अभी टाइम
We
है.
have, we have 5
We
minutes.
have time. Yes. So good. So we have to do it.
ഹലോ
So ready to,
അല്ല അല്ല നാട്ടിലല്ല
yeah. So how many?
ഞാന് തിരിച്ചെത്തി നാട്ടിൽ
how
പോയി
many
നാട്ടില്
attendees are there?
ഒരാഴ്ചയല്ലേ ഉണ്ടാകുന്നുള്ളൂ ആ അതെ അതിന്
Anand, how many people are there? Anand, how many people have come?
So 17, 17.
17. Okay, it will increase. अभी time है.
Okay, we can mute everybody, है ना? Just keep sir unmuted and myself. We can do that, na?
Yes, yes.
And when we'll have some quiz or something, then you can unmute it. Or the person who has to speak, he can unmute it. Okay. Otherwise, keep everyone muted because there will be a lot of noise otherwise.
Oh, yes, sir. Correct.
So is my slide visible?
Yes, it is very much visible.
Okay.
Some water and come back quickly.
Yeah, sure, sir.
मैं हाँ
So we are left with only 2 minutes. So, Anandji, can we start now?
Yes, sir. You can say.
Yeah. So, good evening, friends. And all my dear students. I would say that today's topic we are going to discuss is non-invasive assessment of cardiac disease. Very, very important. Because as a physician, when you come to the practice, this is the most important branch of medicine. And this is the gateway to cardiology. I think once we start talking about cardiology, interventions and everything, all the advanced procedure in cardiology will start with non-invasive assessment of cardiovascular system. And we have a very talented speaker today. She is a senior consultant and in charge non-invasive cardiology in Jayaprabha Medanta Hospital. And she is a pioneer in echocardiography. We all know that and listening to her, and we have been
अभी
having several programs related to echocardiography and allied facility things. And we are planning to have many more programs on our Medanta platform and API platform very soon, like, imaging, CT coronary angiogram, cardiac MRI, and so many things. And we have so many stalwarts waiting to speak, and they are already have made a contact with those stalwarts, and we will in future we are going to listen to them. So I think I must thank all the API stalwarts and our dean, who is not present today, uh, Professor Kamlesh Tiwari. I must thank everybody, and we must have the blessing of Professor Bibi Thakur, the the uh, the prime mover and the father of API in our country. So uh, let's begin with. Let's start the discussion, and I request Dr. Shardha Ranjan to take over the stage. Thank you.
Thank you, sir. Thank you for the kind introduction. So I would like to start, I'd like to thank all the API members also and the senior members of API and sir also for this very good initiative of taking classes, because we can see like residency, medicine residency. I remember my medicine residency, it can be quite hectic. It can be quite challenging. Sometimes your teachers may have time for you, sometimes they may not have, but how to utilize this time when you are at you are at your rooms, you can listen to people who are expert in their own field. And I'll just start today, I'll just give you an window to the non-invasive assessment of cardiac diseases, and we'll take it from there. There are many classes planned in cardiology curriculum. Dr. Ajay Sinha sir has planned a very nice, and he has been requesting to the very senior members, faculty members of national and international fame. So slowly we'll be having such classes which will open your imagination, open your experience to the cardiology in a different way. Uh, Reading theoretical, obviously it will have a theoretical importance. You will be able to answer your questions better, but also the when you listen to the experienced people, the practical knowledge which you will gain will be of much immense help. And that also just sitting in your rooms, you have access to all this. So today I will just
आग लग
start
जाएगी
with a very basic uh,
तो आप जिस हिसाब से कर रही हैं कि हमारी वॉमिटिंग हो रही होगी तो हमको तो ये लगेगा
we'll
ना
have to mute everybody, sir. The person, yes,
चलो अभी चलो
yes, sir. I request everyone to mute themselves. If they have to talk something, they can unmute at that time. So let's mute everybody. Starting with non-invasive assessment of cardiac diseases. So what does it means actually? Cardiac disease, if a person is having, if you have a cardiac patient, the assessment starts since you see the patient. You lay your eyes on the patient. The assessment starts from there only. So that is like history and physical examination. What I'm talking about it. We will not be discussing it in detail, but yes, it starts from there. Once the patient comes to you, he tells your symptoms, he tells you his symptoms, the assessment starts from there. Then you take a proper history, you take a clinical history, you have some kind of diagnosis in your mind. Then you go on to touching the patient, and you take the vitals, you do the CVS examination, you do other system examinations, and there is some kind of picture should be there in your mind before ordering a test. So that is what I would like to emphasize. We'll be seeing lots, and in the coming slides we'll be seeing lots and lots, many number of tests, but you should have a provisional diagnosis before you order a test, and you should know what you are going to gain from the test. So that's how we'll take it. The approach will be that we'll be looking at many modalities, but not in a very theoretical fashion. Not like we'll not do it like all the modalities and indications and contraindications and the diagnosis. We'll take it with the pathology also in between. We'll discuss some case, and in the meantime, we'll also discuss that modality. So just a quick revision. Everybody must be knowing this, but because we are going to see a lot of images, we're going to see echocardiography images. So the anatomy should be revised once. So it's a very simple diagram. The superior vena cava and inferior vena cava. Uh, I hope you can see the pointer. I'll just make it red so it's visible more. So this is the superior vena cava, the inferior vena cava. Superior vena cava brings the deoxygenated blood from the upper part of the body, inferior vena cava from the lower part of the body. This blood comes into the right atrium. It then passes from the tricuspid valve. Tricuspid valve is a valve between the right atria and the right ventricle, which has three cusps, septal, anterior, and posterior. From that, and this valve is attached with, these thread-like structures are the papillary muscles. It is attached with the papillary muscle. The blood then enters into the right ventricle and systole starts. The blood goes into the pulmonary artery. There is a pulmonary valve in between. It's a semilunar valve. We all know from the pulmonary valve, pulmonary artery, the blood goes to the right and left pulmonary artery and to the lungs. From the lung circulation, it gets oxygenated and it comes back to the heart from the pulmonary via the pulmonary veins. These are the left pulmonary veins. These are the right pulmonary veins. They open into the left atrium. A left atrium then opens into the left ventricle via mitral valve, which is a bicuspid valve. It is between the left atrium and left ventricle, which we know. And from there, the left ventricle, the blood goes into the aorta, while systole through the aortic valve, which is also a semilunar valve, and it has three cusps. Both semilunar valves have three cusps normally, and whereas the tricuspid valve has three cusps and mitral valve has bicusp. So this is a normal anatomy of the heart. And from here, the circulation blood goes into the aorta and arch of aorta. These are the arteries which take the blood to your brain. And from there, the aortic branches will circulate the blood through whole of the body. So this is a basic anatomy, very quick revision. Then the pressures in the heart, we know that we know our blood pressure. That is the most simple way to remember. So your blood pressure is 120 by 80. We know that. So what is that actually? So that is aortic pressure. So aorta has a pressure of 120 systolic and is 80 diastolic. Whereas the chambers when left ventricular systolic pressure is same as the aortic pressure, because the blood will be pumped from the left ventricle to the aorta, and at the systole the pressure will be generated. So left ventricular systolic pressure will be 120. Whereas in diastole, the arteries in the diastole will maintain a pressure. So diastolic pressure of the arteries is always on the higher side, whereas the chambers in the diastole are completely relaxed and empty. So the pressure is very less, like less than 10 mmHg. So that we are talking about the left ventricle. It's always easy to remember the left ventricular pressures because that correlates exactly to your blood pressure. And in the same fashion, what will be the left ventricular end diastolic pressure will be same as the left atrial pressure, because in diastole, when the mitral valve is open, these both chambers will have the same pressure. So left atrium pressure and left ventricular end diastolic pressure will be same, less than 10 mmHg approximately. Whereas when we come to the right ventricle is comparatively lower, the pressure is lower there, systolic pressure is lower, because it has to pump the blood only to the lungs, whereas left ventricle has to pump the blood against gravity to your head and to a larger distance. So it has been made like that the systolic pressure generated by the left ventricle will be much higher. The right ventricular systolic pressure normally is around 25 mmHg. It should be less than 25 mmHg. Otherwise, if it is more than it is called, then it may be a pulmonary hypertension kind of a state. And right ventricular end diastolic pressure will be less than 8 mmHg. Same goes with the right atrium, as we learned that end diastolic pressure and the atrial pressures have to be same if there is no stenosis in between. So that we have to remember. If there is no mitral stenosis, no tricuspid stenosis, these both chambers will have the same pressure in diastole. So, this is moving on from here. And pulmonary artery pressure also we have to know. Right ventricular systolic pressure will be similar to the pulmonary artery systolic pressure, and so that will be around 25 mmHg. More than that, we have it. It can be said that the patient may have a pulmonary hypertension. We have to look forward to that. So this is the basic pressures in the cardiac chambers. Why do we want to know that? Because any hemodynamic change, suppose if a patient is of heart failure, there will be change in his systolic pressure, in the diastolic pressures of the chamber. Suppose the patient is of mitral stenosis, there will be change in the pressure of the chambers. The left atrial pressure will be very high because the blood cannot pass from left atrium to left ventricle. There is an obstruction in between. So knowledge of normal pressures of the heart chambers is very important in all the diagnostic modalities. We will see it in the coming slides. Then very quick revision of cardiac cycle. We'll all have to remember that P wave, let's start with the P wave. What happens? P wave is the atrial depolarization. The atria starts to contract. Whatever blood has been collected into the atria that goes into the ventricle will start in. Can you just look at the pointer? We'll start from here. So P wave, the atria contracts and there's atrial systole. The blue line is the left ventricular pressure. So here the when the atria is contracting, is this time the ventricles are relaxed. This is the diastole phase. Then QRS comes. QRS is the ventricular, the signal, the electrical signal for ventricular depolarization. It gives the signal that now the ventricles have to contract. So ventricles start contracting. This blue line is the pressure line. So here the ventricular pressure is around what we learned, that left end ventricular end diastolic pressure is less than 10 mmHg, around 10 mmHg. It spikes up to 80, around 80. When it crosses the aortic pressure, we learned that aortic pressure in diastole is 80 mmHg. When it crosses the aortic pressure, the left ventricle is contracting, it is generating a pressure, and when it crosses the aortic pressure, the aortic valve open. Because it's a common physics that when you put a pressure, when the pressure will exceed the pressure, the obstruction in between, the valve will open. So when it exceeds the aortic pressure, the valves open, aortic valve open. And now this is the ejection phase. This is the ejection phase. The blood goes from left ventricle to aorta and to whole of the body. And slowly this near the end of the systole, the left ventricular pressure starts decreasing. Once it gets below the aortic pressure, again the aortic valve closes. So this is the systole. The left ventricle starts contracting, and in the duration where the pressure is more than, when it is generating a pressure more than the aortic diastolic pressure, aortic pressure, there the systole happens, the blood goes to the whole of the body. And as then starts, the diastole starts, there's T wave. T wave means the ventricular repolarization is there. Now the signal of relaxation has come to the ventricle. The pressure falls down very sharply and it comes to diastolic pressure. So this is how a cardiac cycle, this is how ventricles and arteries behave. With that background in our mind, we'll go on to further slides. So when to perform the test, indications. So we don't need to, remember all this. We know that any cardiac disease, it has to, as sir rightly said, any kind of advanced cardiac procedure, any intervention, it has to start with the diagnosis. Obviously, but if we do not know what is the diagnosis, we are not going to treat. How we are going to treat? So ischemic heart disease, coronary artery disease, if you get a murmur, if there's a patient of valvular stenosis, regurgitation, somebody who has a valve replaced, there is a suspicion of infective endocarditis, all kinds of things, pericardial diseases, cardiac masses. So that's a whole list, that's a whole book. So, but what do we want to know at this stage? What are the symptoms? Suppose we live in a resource limited setting, we don't have all the options to get all the tests done in the world. So what are the symptoms? If a patient is having dyspnea, the cardinal symptoms of cardiology, we all know it is dyspnea, angina, chest pain, palpitations, and syncope. So these four symptoms, anyway, you have to start thinking that this patient may have a cardiac disease. So dyspnea, orthopnea for that matter, if somebody is uncomfortable while lying down, that may be a very cardiac cause for dyspnea, very likely to be a cardiac cause. Chest pain, especially if it is on exertion, that is called angina, we all know. Palpitations, it may be a cause of arrhythmia, it may be a cause of worsening heart function. Syncope, that may be because of bradyarrhythmias, that may be because of aortic stenosis. So, and apart from these cardinal symptoms, if somebody has pedal edema, fluid overload kind of a state, someone is having cough and there is blood coming out in the sputum, someone is very unduly tired, like he was able to walk 2 kilometers, now he's feeling tired, or he's tired than his own colleagues, if tired, he's not able to keep up to people of his own age. Somebody is having a long standing fever, believe me, pyrexia of unknown origin, always, as a medicine people, always get an echo done if somebody is having a fever and you're not able to get a cause. Infective endocarditis can be the reason. And then cryptogenic stroke, like if you get a patient who is young and had a stroke, don't leave it unattended, try to find the cause. And it may be a cardiac cause where there may be, we'll see further. So especially cryptogenic stroke, where you're not finding a cause, get an echo done. Then cyanosis, stunted growth, these can be signs of cardiac disease in a child, cyanotic heart disease. So these are the symptoms where you have to start looking for, okay, now the patient may be a cardiac patient. Now what I should look for, that we'll see. So there are various modalities. There are various modalities coming on, starting from ECG, chest X-ray, echocardiography, stress test. There are a lot of 3-4 modalities in stress test only: treadmill test, stress echo, exercise stress echo, pharmacological stress echo, nuclear imaging, then cardiac CT, cardiac MRI, and cardiac PET. And if we talk about echo, then echo also has in the echocardiography, we have so many modalities which we are doing right now. 2D echo, that is the basic anatomical echo, anatomical imaging which we do. Doppler is for hemodynamics, where we see the pressures, chambers, the flows. Then 3D echo has come, which gives a live 3D imaging. And then transesophageal, where a special probe is there which goes into the esophagus. And because esophagus lies just behind the heart, just behind the left atrium, it gives a very good visualization, because when we do an echocardiography, we see it above the chest wall, so sometimes the imaging can be limited. So transesophageal echocardiography. The newer modalities are strain imaging, where we are looking at at the tissue level of the myocardium. And then carotid and peripheral Dopplers, where we see the vessels, we see the carotid Doppler means see the carotid arteries, we see the peripheral arteries, because any atherosclerosis which is in the heart, which is in the coronary arteries, can be somewhere else also. So peripheral artery disease, carotid artery disease, and then of course fetal echocardiography. And now in India, at some centers, we are also having intracardiac echocardiography, where the camera and the probe that goes with the catheter inside the heart, and an echo is done. So that will be really advanced things. But we'll stick to the basics and then go from there. So basic is that a correct diagnosis is 3/4 the remedy. So that is true for everything, every disease, not only cardiac disease, and not only disease. It is true for everything in life. If we know the problem, then only we can go on to treat it. So first question should be, which test is right for my patient? So think about it, think about that, which test can give you the right diagnosis, which test can tell you the prognosis, because you have to be answerable to your patient, that okay, your disease is mild, your disease is moderate, or your disease is very severe, or you need to get an operated, and then you need to have a treatment plan, whether it is medical or it has to be treated surgically. So before ordering a test, always remember that this is a very important principle in statistics, where we say that Bayes theorem, is posed that the post-test probability of a disease is influenced not only by the sensitivity and specificity of the test, but also by the pre-test probability of disease. So the test may be very good, but if you do not check that pre-test probability, you have to decide. The person who is ordering the test, he has to understand the pre-test probability. Pre-test probability is something that you have to look at the patient, you have to understand the risk factors, what the patient profile is, and you have to understand that, okay, what is the probability of that patient to get a positive test. So just for an example, suppose we look at the patient number A. So his pre-test probability is very low. Suppose it's a young patient, it's a 20-year-old patient with no risk factors, and you are ordering a TMT, treadmill test. So his pre-test probability is very low. So if the test is negative, this yellow line is negative, the test is negative, you know that, okay, the disease is not there. Even if the test comes positive, you are still confused, because the post-test probability is also 50%. So it means that he may have disease, he may not have disease. So at the first place, you shouldn't have ordered a treadmill test. You will feel like this. So this is the pre-test probability. But if the pre-test probability is intermediate, suppose the patient is like in early 30s, 40s, he's obese, he is diabetic, he's not diabetic, he's obese, some mild dyslipidemia, pre-diabetic. Now you're confused whether his chest pain is cardiac or not. So he's an intermediate risk patient. When you order a test, you get a treadmill test positive, negative. You are sure, okay, he doesn't has the disease. If you get a positive treadmill test, you are very sure that he has a disease, because this red line is positive. So with this, you get like 90% of chance that he has a disease. So this Bayesian principles enforce us that we have to order the right test for the right person. If we order the test without thinking about it, you may get confused, and you that is not good for you as well as the patient. So with this background, we'll go on to coronary artery disease. We all know that normal coronary artery with normal blood flow, the cholesterol deposition is there, the plaque atherosclerosis is there, the blood flow will be automatically reduced. So this is a reduced blood flow state. The patient will have chronic symptoms here, angina on exertion, and because the blood flow is reduced. When there is a plaque, there is a thrombus in between, the plaque ruptures and there is a subtotal occlusion kind of thing. It is end-stemming, and if the thrombus is there with a total occlusion, then it develops into a STEMI, that is ST elevation MI. What happens if you get a patient of chest pain into the into your ER? So no need for all the fancy things which we have been talking about. A humble ECG is enough for ST elevation MI. So we should not forget that wherever we are, however limited the resources are, if a patient of chest pain comes to you in an ER and you get a ECG with where there is ST elevation MI, there is no need for any other modality to confirm that this is a myocardial infarction. So this will be ECG. The first one is an interior wall MI, maybe little delayed because we have a development of Q wave, and the ST elevation has started to settle down with the beginning of a T wave inversion, whereas the other one is inferior wall MI, which is there is a a sharp ST elevation. So these kind of ECG, you know that this is a ST elevation MI, no doubt about it. We don't need any other modality. And just very quickly, if you get a suspected ACS, you get a 12-lead ECG, you get a STEMI, as I have shown in the ECG. The only thing which you do is, if it is possible for a PCI-capable hospital, you immediately transfer the patient. If it is possible for you to thrombolize the patient, you immediately thrombolize the patient. You don't need any other thing. Then we are not going to go into detail. I just wanted to reinforce that STEMI, ST elevation MI, doesn't needs any other modality. Yes, if we are confused, we don't have we are not very sure. Here it says non-diagnostic for STEMI. Then we have to, check the serial ECGs. We have to check the troponin, and we have to go further from there. So ECG is the first modality to be used in all the cardiac cases. It can give you loads and loads of information. And why I wanted to reinforce it, just look at the last line, that every 30-minute delay where you do not open a artery and in the myocardial infarction, every 30-minute delay will increase 7.5% risk of 1-year death. So the mantra should be always time is muscle. Try to thrombolize. If you're not, then try to shift the patient immediately to a primary PCI capable hospital. The goal should be less than 90 minutes. Then coming on to echocardiography. Echocardiography is a modality where ultrasound waves, it's less like ultrasound of the heart. The ultrasound waves are emitted from the probe and the image is formed at the screen. And lots of windows mainly we use 3 windows: from where we see the heart from the para-external view, where we cut the heart in the long axis, from the apical view where we see the heart, from the apex, and all the chambers we can see from there. And the third window which we use is subcostal. So this is just to give you an idea, because we'll be seeing these images. This is the left ventricle, this is the right ventricle. Left ventricle is bullet shaped, quite oval. Right ventricle is triangular. Both the atria, this is left atria, this is right atria. And this is the 4-chamber view of heart, a normal heart. We see it in inverted position because the probe is kept at the apex. So this is the probe. So the chamber which is nearest to the probe will come at the top. So this is how, this is how we see it. The pediatric people see it upside down, but this is how adult cardiologists see, and this is how echo is seen. So you can always see this is the interventricular septum, this is the interatrial septum, this is mitral valve, this is tricuspid valve. So this is normal 4-chamber view. Now I told you that yes, in acute coronary, in STEMI, we don't need an echo. But yes, if you have an echo, you do it. So what do you find? What is regional wall motion abnormality? The left side is normal echocardiographic image. The right side is, I think that all of you can, appreciate that this part of the heart is not moving. This is the apex of the heart. This is the septum of the heart. This is supplied by left LAD, left atrial descending artery. So this is not moving, and this part is moving very nicely. So you all can appreciate that this is called regional wall motion abnormality. Like region of the heart is not moving properly. Why this will happen? Because that region is supplied by the artery which is blocked, where the myocardial infarction has happened. So this is a anterior wall MI. This is the we'll go quickly. This is right coronary artery. This is how the coronary artery supply is there. And this correlates with the ECG as well as the echo. The territories which will be involved, the part of the heart which will be supplied by this artery. Suppose we start from the right coronary artery. It goes to the right side of the heart and it goes to the inferior side of the heart. So it supplies the right ventricle, right atria, it will give branches, then it will go to the inferior side of the heart. So it supplies the inferior wall of the left ventricle. This is, see, this you can see in blue. This is the inferior wall. The green will be left anterdescending artery, LAD. It goes to the anterior surface of the heart and it then rotates around the apex of the heart. So anterior, sometimes lateral also. So anterior and septal. It will also traverse inside the myocardium to supply the septum. So anterior, septum, and the apex of the heart is all supplied by the green color, which is LAD. So this all you can see in all the chambers. This all you can see is supplied by LAD. Then the other one is circumflex artery, which goes around the heart in the AV group. It supplies the lateral wall of the left ventricle. So, and with the complications, which you must have seen that sometimes we're not able to diagnose or the patient gets very sick, but acute coronary syndrome can have some complications which can be diagnosed only on echocardiography. So there the role of echo comes. If you're getting a murmur in a patient of anterior wall MI, which you thought that you have thrombolized him and he seems quite stable for 2 days, and then he again worsens. So something has happened. And then listen to it. It may be a ventricular septal rupture. Like here we can see this green part I already told you that it is supplied by left anterdescending artery. So patient of anterior wall MI, LAD blockage, he will have akinetic and diseased myocardium here. And there a rupture happens, that is ventricular septal rupture. Sometimes what happens that mitral valve, what we saw, the papillary muscles and these Caudy. So there may be a Caudy rupture that is called mechanical complication of ACS. So you can have mitral regurgitation as well. So these are the patients who start improving but then worsen after acute coronary syndrome. So there you have to be very aware of the complications and order an echocardiography immediately. So sir will stop and let them. Uh, so so I just put two images and see that everybody is awake or they have slept. If you can answer in chat box, it will be great. What you can see in both of these images is, I'll just tell you for reference that this is left ventricle. This is left ventricle, and the person had an anterior wall MI 4-5 days back. So there is something abnormal which you can see.
Request all of you to take part and write your answer. Give your answer.
Yes, if somebody
What
wants
is
to answer.
there in the first one and the echo thereafter?
Just to tell you, this is left ventricle. A left ventricle where there has been a recent myocardial infarction. This anterior wall is not moving well. And this is left ventricle only. And this is aorta now. This is aorta. This is quite interesting. We can see that there is so you would like to explain?
So
So I think we should discuss a little bit.
Akshay has given an answer like it can be a thrombus, it can be
Good.
myxoma. So with the
Okay.
background of acute myocardial infarction, regional wall motion, which is clearly shown by See, this cannot be a myxoma. This is a soft clot thrombus, and this is moving out of the left ventricle.
Yes. So, as sir has rightly said, with a background of myocardial infarction, and thanks for participating. Yes, it is the thrombus because once you get an MI, the left ventricle is not contracting so well. So there is a stasis. There is there is a low what you call low contraction state. It's not so contracting well. So the blood tends to get accumulated there and the thrombus is formed, which is a complication of this kind of situation. And once it goes here, it is very fatal. It can be life threatening. It can go to the brain, cause a massive infarct. It can go to other organs of the body. So this is what a reason of cardioembolic stroke.
So remember, yesterday we saw a patient, young
Yes, sir.
patient with anterior MI who was seen in periphery, and somebody reported, that there was no thrombus. But then when you examined the patient, you did the echo, and you could find that there's a LV sitting at the apex.
Yes, sir.
Sorry, clot sitting at the apex.
And
So
he
that's
came with a minor stroke as well, sir. He had already had a stroke.
already had a stroke. Yeah.
Yes, sir. So the message is there कि once a patient of myocardial infarction gets out of the sick window, you treat a patient and he is doing okay, then also these kind of complications can be there, which is hidden. See, this thrombus will not cause any symptoms. You will not get to know until and unless echocardiography is done. But once this goes out, to the aorta and to the other organs of the body, it can be fatal. So that is the message there. So that will come on to the stress test. Stress test, there are a lot of stress tests. We'll go quickly towards it. All the tests, the basic physiology which they apply is the same. So what we do, whenever we put a patient, we have talked about the acute coronary syndrome. We have talked about the acute coronary artery disease. But what if somebody has an underlying chronic coronary artery disease, where he's having some chest pain on exertion, or these kind of patients who have not landed up into emergency, but we want to know what is causing their symptoms. They have some dyspnea, they have some chest pain. So we put them to stress test. What are we actually doing? All there are many stress tests, but the basic physiology is that when you put a person to stress, when you put a person to exercise, the energy demand of exercising muscle increases. What the brain does, brain knows that okay, now the person has to exercise, now we have to get active. So it decreases the vagal tone, it increases the sympathetic tone, it increases the sympathetic activity. That leads to, and from here the person who is exercising, the venous return also increases. If you're doing a dynamic exercise, the venous return increases, total body oxygen uptake is now high. Sympathetic tone when increases, vagal tone decreases, it increases the heart rate. The venous return which has increased, that will increase the stroke volume. And as we know, cardiac output is heart rate into stroke volume. So the cardiac output will increase. So when the demand is increased, when you are exercising, the heart has to fulfill that demand. So heart will start beating more. It will start beating, ejecting out more blood as a stroke volume to meet up that oxygen demand of the body. But if the heart has to work more, it will also need oxygen, it will also need nutrients. So now the coronary blood flow also has to increase simultaneously. Then only the heart can increase the whole body output, the whole cardiac output. So now in a normal person, the coronary blood flow also increases, the coronary vasodilatation is there and increases. But what happens if the person has diseased arteries? This is on this spectrum, we see that there is a subsequent decrease in coronary blood flow. Somebody who has atherosclerosis, which is progressively increasing, and this is a very tight lesion. So this shows decrease in coronary blood flow. And if that person is subjected to exercise, now there is oxygen demand has increased. The patient is exercising, so he needs more oxygen. The heart needs more demand. The heart needs more blood supply. So as we go to if a normal person is exercising, he may be able to meet that demand. But if a person with atherosclerotic heart disease, coronary artery disease has to exercise, the coronary blood flow will not increase that much to meet that demand. And this will lead to ischemia. and that ischemia we catch in the test. So there may be perfusion abnormality. These are very sensitive. Nuclear imaging test. We'll go through it if you can catch it in a very early phase. Then you can catch it as diastolic dysfunction. Before systolic dysfunction in echocardiography, you get diastolic dysfunction. After that, if you make the person exercise more or if the lesion is more tight, you get systolic dysfunction. It is that regional wall motion which I showed you. When the person will exercise, it will come up. When the demand will increase, then only it will show up. If he is at rest, the ejection fraction will be normal. Then you get changes in the ECG. Before ECG, you get changes in echocardiography, but that is a very sensitive thing to notice. So ECG changes are picked up more easily. Then you get ischemic ECG changes. Then the patient gets pain. So before a patient is getting angina, we can catch all these things if we make the patient to exercise, because here we make a demand mismatch ratio. So the demand is more and the blood flow is less. There is a mismatch and thus ischemia occurs. So that is the basic principle behind all the stress tests. So patient suspected of coronary artery disease, we can get these tests done. So TMT, we all know, treadmill test. We know that there's ST depression, ST elevation, how to read a TMT. We can go through it. So person is made to exercise on the treadmill if who has a normal ECG on baseline while on exercising in stage 1 only, like it with a mild exercise only, the heart rate increases to 148, and where you get a sharp ST depression, horizontal more than 2 ST depression in the 1, 2 and other leads as well. And there is an elevation is in AVR also. So these are the markers of a significant coronary artery disease. So this is treadmill test where just ECG leads are attached and the person is made to walk on treadmill. And because of the physiology which we discussed, he will have ischemia and will have the ischemic changes in the ECG. So this is the basic treadmill test. It is very good. It has good sensitivity, but sometimes if the baseline ECG is, there are some STT changes are there, then we have to look for other tests. If the ECG is uninterpretable, like somebody has a RBB or LBB already in the ECG, then you will not get that much of information because the STT changes may be due to the underlying bundle branch block. So there we do an stress echocardiography where we do the same process, but then at peak of exercise, we also look at the echocardiography. So as we can see, the sensitivity and specificity both increases than a treadmill test. If the person is not able to exercise, we can make him do pharmacological stress echo, where the normal myocardium will see dobutamine we use as a pharmacological agent. We inject dobutamine. Dobutamine will increase the inotropy as well as chronotropy. It will increase the heart rate as well as the contraction of the myocardium. So that also indirectly increases the myocardial oxygen demand. So with the increasing heart rate, now again the coronary blood flow has to increase. If if the arteries are diseased, so the heart will not be able to increase the coronary blood flow and patient will get ischemia. So the basic physics is there, but because the patient is not able to exercise, we are doing that with dobutamine. So it is a very good test. Here we can see the ischemia. Here we can also, get an idea about the viability. We can also know that if that part of the heart is a scar. So indeed, we cannot go into detail right now, but sometime we can do. So this is the left ventricle at rest. It is contracting very nicely. These two are at rest, left side of the image. Once we increase the heart rate, it goes up to 100, 810 with the help of dobutamine. There's some kind, so you can see that there is a regional wall motion abnormality in the top, top of this is the septum. And here also the top of the circle. So this is the septum, the anterior wall and septum. So it means that the lesion is somewhere in the left anterior descending artery. So another benefit of a stress echocardiography is that we can define the region. We can know that okay, if this region is involved, then the more we can attribute it to the same artery. Whereas in the treadmill test, we cannot do that. Same thing we do nowadays in nuclear imaging, because echocardiography can be really subjective. It is very operator dependent. So nuclear imaging is a more sensitive test. It's a better test. but the concept again, as I said, that it is same. So single photon emission computer topography is now done, which is where the gamma camera is there, and isotopes, labeled radioactive isotope labeled technique is there, where technetium or thallium, not the normal molecules, but they are radioactive. The radioactive technetium and thallium, they are labeled, and they are injected inside in the patient. And where the perfusion will be more, they will be collected more. Where the perfusion will be less, where the blood supply will be less, so they will be collected there less. And these radioactive molecules will then emit gamma rays from there. Suppose they go into the heart, they will start emitting gamma rays. The more the concentration of the blood, the more the concentration of these radioactive molecules there, the more the concentration of the gamma rays which are coming from there. And that is taken by the software and interpreted as an image. So this is the nuclear imaging SPECT, which we call as commonly known as stress thallium, but now thallium is uh, less widely used, and technetium they are using more. So this is normal. This is the normal perfusion. This is the cut section of the heart. Here also it is, so at rest, at stress. Then if a person has infarct, the person has already a scar, so at rest also there is less perfusion in this area, and at stress also there is less perfusion, because it is infarcted, there is nothing to go on there. But if a patient who has ischemia, so at rest, we can see here that the perfusion is normal, but when the patient undergoes stress, here the perfusion becomes less, and we can see that, okay, there is a deficit in perfusion. It means while giving stress to the patient, there is a demand and the supply mismatch, and this region goes into ischemia. So that is more sensitive marker. And similarly, PET is also done. PET has even better sensitivity, and the imaging is more good. Here we can also see in the SPECT we can see perfusion, but in PET we can also see the metabolic activity which is going on. So there is a FDG PET which is done, which also looks at the metabolism. So like normal, both perfusion and metabolism should match. So blood supply is there, so metabolic activity at tissue level should be same. If there is an infarct, it's a matched effect. No blood supply, no tissue level activity. But if there is a perfusion metabolism mismatch, like the blood supply is not there, but there is some metabolism going on, it means that the tissue is still viable. And if we open the artery, then we can have some benefit from that. So that is perfusion metabolism mismatch. So these are the things where we can understand at the tissue level that whether the tissue is viable or not. So these all can be picked by PET, also used as in a coronary artery disease now. Then CT coronary angiography, this is like an angiography, but non-invasively done. Now we have softwares where we can just inject a dye into the vein, and from in the normal CT machine we can take cuts like this, where we very beautifully we can see all the arteries. These white specks are calcium. We can see the calcium deposition. We can see the luminal stenosis, and with 3D model we can very easily we can understand that if something major is going on.
There is a
Yes, sir.
question coming by, written by Dr. Arman Misra.
Yes, sir.
Ma'am, what are the contraindications of TMT testing? What is the risk of AMI episode during the test in high-risk patients? So let's quickly take this question up, then we'll
Yes.
progress, move
Yes,
forward.
sir. So as I told in the beginning of we should know which test to order. So if you have a patient you are very suspicious kid, he may have a cardiac disease and he has angina even on, walking a little bit. For those patients, we do not want to order TMT. For those patients, you should go for either angiography. If you are very sure with why do you want to put that patient to at risk. So we always have a checklist. If somebody had an acute MI, even if they do not know that they had an MI, but acute chest pain, then always do troponins before, putting them on treadmill. So we have to rule out acute coronary syndrome always. And if we have done that and we have taken proper history, there is very less risk, obviously. And contraindications is like there is a complete list, but yes, accelerated hypertension, chest pain at very minimal exertion, acute coronary syndrome, very severe aortic stenosis. These all are the contraindications. So very quickly we'll go to the POCUS. I'll just tell them briefly about POCUS. What is POCUS? I think that everybody knows. Focus is point of care ultrasound, what we use in emergency. If a patient comes to you in shock and you have an ultrasound machine, so what all you can do? Do we don't need an echo to know that he is in shock, but yes, we need an echo to know that what is the etiology of the shock. In medicine emergency, you can have a hypovolemic shock, you can have a cardiogenic shock, you can have an obstructive shock, you can have a septic shock. So just remember that in cardiogenic shock, the cardiac output is low, central venous pressure is increased. How do we know that? I'll just go quickly. Just look at the apical four chamber. Is if all the four chambers are contracting well and they are not very dilated, it is unlikely that patient has a cardiogenic shock. And all the walls are contracting well. It doesn't seems very sluggish. It is contracting well, and that any chamber is not very much dilated. It is unlikely. You are now thinking that okay, the heart function is normal. I should look after septic shock. I should look for a cause for hypovolemic shock. But yes, the work is not half done. Second, you look at the IVC. If IVC is full like this, then you have to wait. If the IVC is collapsed, it means it's very thin. I don't have the picture, but it is very thin. This is a full IVC. It is not moving with respiration. So it's a full IVC. If the IVC is full, you can have a cardiac cause. If the IVC is very collapsed and the chambers are moving well, it is less likely that the person has a cardiogenic shock. Then in the POCUS, sometimes the patient who is very sick, he may have a pericardial effusion, he may have a cardiac tamponade. It is very easy to find out. Just put your probe in the subcostal area. You can see the heart dancing in between, and you can see there is a thick layer of black shadow. That is fluid. So that is pericardial effusion. So these things you can very easily pick up. And just I have put there, okay, if you have a machine, always try to put, even if you don't know a proper ultrasound, if you have a machine lying down in your emergency, try to put it on the heart. Try to look at the subcostal, try to look at the parasternal views. You will find out something. This you should not miss. This is a correctable reason. If there is a tamponade, it has to be drained immediately. Then, so what this picture just I have showed you, that this is a normal ejection fraction and this one is a reduced ejection fraction. See, the left ventricle is ballooned up. It is not contracting well. So this is a very reduced ejection fraction. These patients are of, the ejection fraction is less. So these patients may be in cardiogenic shock. And then if you start putting, sometimes you can, this is an aortic dissection, this is aorta, and there is a flap which is moving. This is an aortic dissection. These are emergency kind of things which can be picked up if we start doing POCUS, point of care ultrasound. So we'll take a little break and we'll do a quiz. So a person, a 56-year-old female who is undergoing treatment for CA breast, she comes to ER with severe breathlessness. So what may be the etiology? I'll just tell you where my pointer is. This is right atrium, the other one is right ventricle, and something is going on there. And here we can see the pressure. These are pulmonary artery systolic pressure, which are increased. That much I will tell you. You can see something floating in the right ventricle, and the person
Very
is off.
simple. Can somebody write the answer?
Yes. This is something all of you should know. In the ER with a history of carcinoma, the person comes with severe breathlessness. The ECG just shows sinus tachycardia, not much.
Because you get it after.
Pardon?
So most of the people have answered like pulmonary embolism.
Good.
Yeah.
So that's how it looks. So that's a very good thing that you can see there is a thrombus. There is a thrombus which we cannot see it migrating, but yes, if it is in the right ventricle, some part of it will go to the pulmonary artery. And it was confirmed on CTPA. See, these are the thrombus on both the pulmonary artery. The thrombus is stuck there. So this is a case of pulmonary embolism. And what happens, we all know the thrombus is stuck in the pulmonary artery. There is a sudden increase in RV afterload. RV cannot pump. Where to pump? There is a sudden obstruction in after, sorry. So there is a sudden increase in RV afterload. When it happens, the RV dilates. It doesn't knows what to do. It will just dilate, and there is a lot of pressure there. RV ischemia occurs. RV contractility goes further down, the RV output decreases, because whatever RV will push through, that only will come to the left atria, that only will come to the left ventricle, and that will generate the cardiac output. So the patient goes into shock also, because there is no cardiac output from the right ventricle. So left ventricular will also go down. There will be low cardiac output. The blood pressure will come down. The more the blood pressure comes down, the RV perfusion gets even more decreased, and then this is a vicious circle. The patient goes in, cardiogenic shock and death very quickly. So these kind of emergencies we have to understand. If there is a suspected PE, if you have an echo, then diagnose it quickly. You see at RV afterload. RV afterload is there, RV is dilated, and the pulmonary artery systolic pressure is there. Even if you are not able to find the thrombus, if the history is acute, then you have to go for PE specific treatment, especially if the person is in shock. And if we have CT angiography available, then we can always do it. So that's how it's done. Coming on to valvular heart disease, X-ray we have not discussed, but X-ray still remains. Can anybody tell which disease this X-ray shows? I think we have to go quickly, sir. We are getting short on time. So this is the X-ray of mitral stenosis. Lot of information still we can get from X-rays. There's a straight heart border, left atrial enlargement. The carina is wide because the left atria is bigger. The pulmonary venous hypertension signs are present. And so this is X-ray still can give a lot of information. Valvular heart disease, rheumatic heart disease is the most common disease still which we are getting, and the whole spectrum. Borderline we can diagnose on echocardiography, and after that only when the patient gets more sick and gets to moderate or severe disease, then only clinically they are picked up. So somebody, if you have a suspicion, always get an echo done, because their life course can change with the penicillin prophylaxis, and sometimes the mild disease you cannot pick up clinically, so that can be done by echo only. So any that kind, the person, you should order an echocardiography. Mitral stenosis, where the mitral valve is thickened and fibrosed, you get a fish mouth opening, the left atrium is bigger. So this is a case of mitral stenosis. For all the valvular lesions, I must tell you, echocardiography still remains the only good test, which can give us a lot of information. Here, the advanced test do not have much role, because the valvular, this is a mitral regurgitation on 3D. Then bicuspid aortic valve, it looks like something, it looks like this. A quick quiz again, we'll see. 24-year-old male. This is his echo, which I have shown before. So it's a bicuspid aortic valve. And the person has hypertension. He's 24-year-old, 160/94, and he has effort dyspnea. We get something like this when we put a Doppler to his arch of aorta. So what may be the diagnosis? He's on antihypertensive since he was 18. I think many of must be knowing this answer. Very common association of bicuspid aortic valve is coarctation. If you get something like this, always check the pulses. If you have a patient who is young and hypertensive, always check the pulses. In these patients, there may be a chance of bicuspid aortic valve, and the most common association of coarctation of aorta, where there is patient present with hypertension, and the lower limb pulses are feeble. So then aortic regurgitation. I think, sir, we'll conclude a little bit, because we'll tell something about MRI. Cardiomyopathies. Cardiomyopathies is where we have a new modality, cardiac MR, which is very important, because echocardiography is not very good for myocardial structure. Myocardial, what is the quality of the myocardium? Is it fibrotic? There is a scar. Echocardiography cannot pick up that much. So this is where MRI has a role. Myopathies can be divided as hypertrophic, dilated, ARVC, restrictive, or sometimes unclassified. They can be suspected on ECG, but always the confirmation is by echocardiography. And after that, to better know it, better classify it, whether it needs, what kind of treatment plan we need. If the cardiomyopathy is very severe, it is prone to sudden cardiac death. These all information we get from MRI only. So MRI is very good to differentiate the types of cardiomyopathy. To know the early gadolinium enhancement can tell you about the fibrosis, the scar there, and the other imaging like T2 imaging that can tell you about tissue edema. If somebody had a myocarditis, it can diagnose this, whereas echo is not very good modality to do so. And hypertrophic cardiomyopathy, if a person is on sudden cardiac death risk, then MRI is very helpful to quantify what is the scar burden, what is the fibrosis burden there, because that fibrosis, that scar will generate the ventricular arrhythmias, which will lead to sudden cardiac death. So that is the point about it. Any cardiomyopathy, the myocardium is diseased, which can generate ventricular arrhythmias and cause death. So that can be picked on MRI only, and if we pick that, it can the person can be given a primary prevention of AICD. Cardiac PET is also very good in imaging, other like perfusion, we see coronary artery disease, we saw cardiac PET. But for other diseases also, it's very good because it like PET scan. PET scan, you must have heard in cancer also, we pick up metastasis with that because it picks up the it picks up the places where metabolism, where the activity is going on, the activity is high. So fluorodeoxyglucose, if it is labeled, it will pick up where the inflammation and high metabolically active places. So inflammation is like in sarcoidosis. If there is an infection going on, where there is infection, the uptake will be really high. So you can pick up infective endocarditis if you're not getting on echo, or we can vascular graft infection. Somebody had a surgery, now that graft is infected. These all things can be picked on PET. So PET is also very good for all this. Then stress cardiomyopathy, just look that it is picked on echo only, where the your question may come in your exam, Takotsubo cardiomyopathy. Takotsubo is an octopus spot. So you see the left ventricle here, you just convert this octopus spot. This was used in by Japanese to catch octopus. So you just convert it, it looks like a pot. So this is stress cardiomyopathy. A normal person with a normal heart undergoes a very tremendous stress, somebody has died or the person has went into an accident. With that stress, there is so much of sympathetic overactivity that the left ventricle fails for a transient phase of time. That is stress cardiomyopathy. This is a reversible cause of LV dysfunction, and it sometimes can be reversible. We got a very rare case of reverse stress cardiomyopathy where the ballooning was in the basal part of the left ventricle. We are able to publish it. Atrial fibrillation. If you get a patient with atrial fibrillation and heart failure, always think of cardioverting it. Before cardioversion, we need to get a transesophageal echo done. So this is one modality I would like to highlight it. Transesophageal echo is good for many things. It sees the heart very closely from behind. And one thing which we use most routinely is to exclude out a left atrial appendage thrombus. So this is left atrial appendage seen in 3D, and this is anatomical visualization. You can see that it is the 3D imaging is as good as anatomical visualization. So to rule out the thrombus before cardiovert, you have to rule out the thrombus, otherwise the thrombus will go and create a cardioembolic stroke. Strain imaging is an advanced modality. It picks up subclinical LV dysfunction. Cardiac CT. Now we have 3D cardiac CT. So this is the patient. This was my patient. This is the left ventricle. The left atrium is very huge. This person had a mitral stenosis, and after that she was operated with MVR. Mitral valve replacement was done. But after the surgery, she developed a very big aneurysm. This which you can see lurking behind. So this is a very big aneurysm picked on cardiac CT because it is behind the left ventricle. So these kind of things we can pick up. So just winding up, this a case, a 48-year-old male presented to us with a heart block. So ECG was done. How multimodality imaging plays a role, this will summarize this. ECG showed complete heart block. Patient was having giddiness, not kind of syncope, but for a young patient to have this kind of heart block was not understood. So echo was done. Echo showed okay, this is not moving. Echo showed some LV dysfunction, and we suspected, okay, it may be sarcoidosis. Then MRI was done, which collaborated with the echo images. There was enhancement in the epicoceptal region of left ventricle. in the MRI only lungs was also seen. There were nodes filled up everywhere. The lymph nodes were enlarged with the parenchymal disease as well of the lungs. Cardiac PET was done. The disease which was there in the CT, it came out to be acutely inflamed. It is the acute condition because it all lighted up in the PET. It means that acute inflammation was going on, and then biopsy was done, which showed that these lesions were actually consistent with sarcoidosis. So this is how it all sums up. And as sir said, that we are very keen on teaching and doing programs on clinical cardiology and echocardiography. We have done 3 conferences, and this year we'll be doing 4th. And also we have a fellowship program in clinical and non-invasive cardiology, which is led by sir. Thank you.
Thank you very much. Great, great talk. If somebody has got any questions,
I
at this
finished
point-
right on time.
yeah, you're right on time. Yeah, but then very elaborative talk, very illustrative talk, right from ECG to high modality of imaging. So we have to, we have to learn a lot, and see if you are doing echocardiography in emergency, just put the probe and you get the diagnosis. And she has shown you several examples, right from LV dysfunction to pericardial tamponade to LV thrombus or thrombus inside any chamber, thrombus in migration. Everything will give you a diagnosis. So echo is very, very important for diagnostic evaluation. Secondly, she said was ECG changes during exercise. It's very important. Horizontal ST depression is a manifestation of ischemia, whereas ST elevation is a manifestation of myocardial infarction, and there can be several variation. You can have a biphasic T wave. You can have a changing morphology or dynamic ST changes. Everything is very, very important. So right from ECG, she has taught you how to look into the echocardiography, and including advanced imaging. We can make a diagnosis of sarcoidosis, which is not uncommon. So that's another lesson she gave. So thank you very much. If you have any question at this point of time, young individual with dilated cardiomyopathy, usual causes to suspect. You can take up this question.
Yes, sir. Young individuals, very rightly you said, always look for reversible causes. See, you have to see thyroid. If it's a female, look at the peripartum aspect, as I showed you. So always look for reversible causes, because that you can treat. So thyrotoxicosis can have this. Somebody who have an uncontrolled diabetes, they may have a reduced LV function. Then chronic kidney disease, any kind of severe other organ system disease can sometimes have a reduced LV ejection fraction. So before labeling them dilated cardiomyopathy, always look at the other parameters. Then inflammatory diseases, which I showed, like sarcoidosis, may be there, so that can be ruled out with history and simple blood test. And then LBB, somebody who has an LBB, simple LBB on ECG, they may, because of the dyssynchrony, they may have a dilated cardiomyopathy.
So if there are no questions, we will conclude by thanking Dr. Shardha Ranjan. So it's a very good illustrative talk. Thank you all. Look forward to seeing you again in the future. Like during the Holi, we are not having session on the Friday, but we'll definitely have a good session after that. So thank you all. Good night.
Thank you, sir. Thank you.